I decided to present shock, but then I realised that actually it's probably a stupid thing to present because it's just massive and there's loads of different types of it and it's trying to cover quite a lot. So what I'll do is I'll just do some basic stuff first and then we'll talk a little bit about some physiology manipulation and what we do when we see patients that are essentially shocked in front of us. And also we'll talk a little bit about endpoints of shock and what essentially be more of a practical point rather than evidence-based, I'm afraid. So a lot of this is my musings rather than any evidence-based, so people might disagree or agree, we'll see. So I think for people doing their exams, I think if you can't define shock, you don't get any marks. Okay, so that's the first thing to say. The first thing always is be able to have a definition, especially in an oral exam, to come out with a decent definition. The examiner goes, okay, this guy knows what he's talking about. The main definition that a lot of people use for shock is basically it's circulatory failure causing inadequate oxygen delivery to meet the cellular metabolic needs, producing cellular or tissue hypoxia. Okay, so if you come out of that with an exam, you know, the examiner straight away go, okay, this guy knows what he's talking about. So it's really important to get your definitions in. Okay, so some very basic physiology, this is stuff that you should really, that we used to teach the surgical trainees on the CRISP course, but I always look at the body in terms of a flow equation, and the biggest flow equation that you've probably heard of is current and resistance. Have you heard of Ohm's law, guys? Yeah, have you done physics before, GCSE, where voltage equals current times resistance? So voltage is essentially a potential for flow to occur. Current is the flow of electrons, and resistance is obviously the resistance to that flow. And this can be put into any sort of flow of fluid, and in the body that you can equate that to mean arterial pressure is the potential to flow occur. You know, if you turn on a hose pipe, you won't get any flow if there's no pressure difference, will you? Okay. Cardiac output is measured in litres per minute, flow is measured in litres per minute, so therefore that's flow. And obviously systemic vascular resistance is resistance to that flow within the body. This is a very oversimplification of everything within the body, but let's just start with this anyway. And also we know that cardiac output is essentially stroke volume times heart rate. And the determinants of stroke volume, preload, afterload, contractility. Preload's all about Starling's laws of increasing end diastolic volume and stretch the myofibrils, leading to increasing force of contraction. That's different from contractility. So some people get confused between force of contraction and contractility. If you look at Starling's laws, if you give somebody an inotrope to increase their contractility, what you're doing is shifting that curve upwards. So for the same preload, you're getting a higher stroke volume or higher cardiac output. Okay, whereas force of contraction is more going along that curve. So the more stretch, the more force of contraction. Okay, more in, more out. So types of shock. So classical teachings, there's 4 types of shock. So it's cardiogenic, hypovolemic, mechanical, and distributive. Again, in an exam, when you're asked about classifications, it's always good, or you're asked about something, you're always good to classify your answers. So cardiogenic, you can classify it into muscle, valves, or electricity. The heart is a pump. It needs a muscle, which needs an oxygen supply. It needs valves for the flow to go in one direction, and it needs coordination. Okay, and if either of those 3 are out, then obviously you're going to get a low output state. And muscle, you can then you can then classify that further. So you can have, I know, cardiomyopathies, all the different types of cardiomyopathies, ischemic heart disease. You even have congenital muscular problems. There's massive amounts. So if you actually classify, you can get more differential diagnoses. Okay. Hypovolemic, if you classify it as fluid in, fluid out, any sort of imbalance between those two, people straight away go, oh, it's hemorrhage, but actually the most commonest cause of hypovolemia is fluid out of the vascular system, rather than just hemorrhagic. So always look at fluid in, fluid out. So fluid out. It could be diabetes insipidus, could be diabetes mellitus, it could be, you know, hemorrhage, it could be any other sort of hormonal imbalance that causes a fluid balance problem, okay? And fluid in is normally because we haven't given them enough fluid, or they've come in without dehydrated for any other reason. Nausea and vomiting, all those sort of things can cause that imbalance. Distributive. Now going back to the original very simple equation of cardiac output times systemic vascular resistance leading to, you know, your MAP. If you reduce your systemic vascular resistance for any sort of reason, your MAP will reduce. Okay, and sepsis causes vasodilatation, as we know. Anaphylaxis is you know, a profound vasodilatory and cardiogenic really as well, and neurogenic as well. So people get confused between spinal shock and stuff and things, but actually there is a difference from a cardiovascular perspective. It's loss of the sympathetic tone. Okay, so loss of sympathetic tone, that could be iatrogenic, that could be us doing spinals, epidurals, and losing that sympathetic tone, or it could be a complete transection of the cord, losing that sympathetic tone. And you just remember that your parasympathetic tone comes from craniosacral, so you get an unopposed parasympathetic activity once you've lost that tone. And if it's above, if you get a lesion above, say T2, T4, where your cardiac accelerator fibers come out, you'll get a bradycardia, which is converse to the normal sort of shock that we normally get with distributive shock. Okay, and then the other thing is mechanical, so RV filling restriction. So anything that's going to stop the heart from filling. So pneumothorax, it's going to stop the heart from filling because the pressure pushes on the right side of the heart. Tamponade, those sort of things will stop the heart from filling. And then you've got outflow obstruction, so having a big PE of saddle thrombus or something like that. It's just stopping that flow, because remember the heart's in a series, isn't it? If you don't get blood through the right side, you can't get blood through the left side. So if you obstruct any sort of outflow or inflow into the right side, you're going to get mechanical shock. Okay, so these are that's the sort of classical teaching. All right, those are the sort of definitions of shock that you'd expect in a sort of junior registrar exam or SHO exam. Okay, the reality, it's a bit like that. Okay, so you look at a patient, you see how, you know, you've got lots of different people looking at what the one patient, and they'll all see different patterns. Okay, so it's about working out the patterns within that system to working out what's going wrong with your patient in front of you. Okay, nobody really falls into one defined category of this is definitely distributive or this is definitely cardiogenic. You know, so it's about working out exactly what is going on with your patients. Okay, so the whole point is working these things out. So how do we treat this? Well, you treat the cause. Okay, so it's really important. That's the main thing. Okay, when you're resuscitating a patient, you should be thinking, what's causing all of this? Because if you don't know the cause, you don't know the prognosis, you can't fix it. Okay, so it's really an essential part of trying to get a diagnosis for anybody who presents to you with shock. I think that's my. If you could take anything from this, is just think about what's going on with the patient. It's quite easy to turn up and go, they've got a low blood pressure, let's give them some fluid, let's give them some inotrate, let's give them some vasopressin. But actually, if you don't actually understand what's causing it, you can't really fix it. Okay. And often, you know, as with all these things, it's never an A, B, C, D approach. It's always you're multitasking, aren't you? Saying, well, what's going on whilst you're resuscitating a patient? You're thinking about the main aspects. And if you notice, a lot of people, you know, when they turn up, a lot of the more senior trainees or consultants, they start looking at the notes whilst the resuscitation is going on, because they're trying to work out what is going on. Okay, it's not just all about putting the cannula and getting fluids and all that sort of stuff. So treat the cause is the underlying thing. So, but what can we manipulate? Well, DO2 is delivery of oxygen to the tissues. Okay. And it's all about trying to manipulate that equation. Without the oxygen into the tissues, into the cellular level, you're not going to, by definition, you're not going to sort out the shock system. So there's two things that we can manipulate. There's cardiac output, okay, or the delivery of blood to the tissues, which is involved in cardiac output. And there's the oxygen content, okay, of the blood. So the oxygen content of blood is saturated hemoglobin and dissolved content. All right, you understand that? Yeah, happy? Most of it is all in the hemoglobin, okay? You can't really affect the dissolved content of oxygen within the blood unless you put someone in a hyperbaric chamber, because you're talking 0.003 kilopascals, you know, of contribution. So then you look at hemoglobin. So about hemoglobin amount, well, there's no evidence regarding increasing hemoglobin. You would suggest that if you're trying to increase oxygen delivery, you want to just give them more hemoglobin. Why don't you just transfuse them up, and then that will increase the oxygen carrying capacity of the blood and get it to the tissues? But we know that doesn't work. Okay, allergenic blood that's stored has not got a lot of 2,3-DPG for start. Increasing your, so which basically means that it can take oxygen up, but it can't give it out. Okay, increasing your hemoglobin will increase your viscosity. So when you get down to laminar flow, which is at lower, smaller capillaries, you're actually reducing flow through the tissues. And it has been covered in previous talks on this, that, you know, the TRIC trial looking at all those things. That being said, if you are bleeding, actively bleeding, you obviously need blood replacement. Okay, but overall increase in hemoglobin, you know, isn't going to work. Okay, so hemoglobin saturation. All right, so that's the main thing that we can do. So if somebody is in respiratory failure, you want to make sure that they've got enough oxygen binding to hemoglobin. But actually, again, there's not a lot there either. So if you increase your, you know, high oxygen requirements or high oxygen amounts in the blood, can lead to increased mortality on ICU patients. So hypoxia is bad for you. Okay, we're never designed as human beings. We have been breathing 21% oxygen for millennia. And it's only in the last couple of 100 years oxygen as a gas that's been used medically has become about. So our bodies aren't designed to cope with free radicals and the complications of oxygen toxicity. Okay, so really there's not a huge amount that we can manipulate there. But again, you need to just think about these things. So that leaves the cardiovascular parameters. So the first thing we look at is preload. Okay, what do we do? Okay, so do we give a fluid bolus? If we do give a fluid bolus, what do we do? What do we give? We talked about blood. We haven't talked about colloids. So colloids. So there's three types: starch, gelatin, albumin. Okay, starches were sort of. There's a guy called Professor Bolt who did a load of research which was all found to be fake on starches, and all that research has been re-reported, and essentially mortality is higher and acute kidney injury is higher with giving starches. So do not give starch, okay? Everyone gives you a bag of starch, throw it in the bin, okay? It is the devil. It's also, if you think about it, would you give something IV that your body can't break down? So if you give somebody a bag of starch, that's in their reticular endothelial system for the rest of their lives. Would you want that in your blood? I don't know. Okay, gelatin. Okay, so the evidence for gelatin isn't brilliant. It's not bad, but it's not better than just giving crystalloids. And again, gelatin, there is an anaphylaxis risk to it. So if you've got somebody who's shot, do you really want them to have an anaphylaxis, even if it's 1 in 10,000 chance? I still prefer, or 1 in 1,000 chance, I still prefer not to. And also gelatin gets freely filtered by the kidneys. It's about 36 or 40,000 kilodaltons, so it actually does get filtered by the kidneys. So it doesn't stay in the system that much longer than crystalloid, okay? Albumin, well, albumin is something that we've all got in our blood, and it's probably okay. Okay, in the noughties there was the SAFE trial, and it went out of fashion a bit. People say, "Oh, there's no point in giving it," and there wasn't any difference between albumin and saline. And actually, within that trial, there was some people looking at it saying may have increased mortality. But since then, There's been a few more trials. The biggest one, I think, is the Albios trial in Italy, which looked at about 1,400 people, and it was equivocal. Some people say it's slightly better mortality, especially in patients with sepsis. So albumin's probably okay. All right, so albumin's probably okay, but it's expensive, and it is a blood product. So then we go on to the crystalloids. So the crystalloids, what we give normally, isn't it? So normal saline it's really abnormal, isn't it? Okay. Does anybody know what's in saline? Give the. It's all quiet here.
Sodium chloride.
Sodium chloride. Yeah. How much?
154 sodium and 154 chloride.
Absolutely, yeah. So it's 154 sodium and 154 chloride, isn't it? And our normal chloride level in our blood is about 80 to 110, isn't it? Or 105. So actually, you're giving them a massive amount of chloride, okay? And it is actually essentially acid. So you're giving them acid. So it's quite, and the only really time to give it is with all these things. So you've got a patient who's losing a lot of fluid from losing a lot of acid, so energy losses, that sort of stuff. Then it might be appropriate to give saline back. So large doses of normal saline causes metabolic hyperchloremic metabolic acidosis, and which can worsen things. So it's not the best of solutions. Balanced salt solutions, again. It's balanced salt, so it should mimics your normal, what's in your serum. But again, it's 131 millimoles of sodium. You only need 1 to 2 millimoles a day of sodium in your blood. So one bag of Hartmann's is enough of your whole sodium content that you need within the day. We normally give 2 or 3 bags, don't we? So you're still overloading people with sodium given Hartmann's, but it's probably probably the best solution to give, probably. What about lactate? Is lactate a problem in Hartmann's? So if you've got somebody who's hyperlactatemia, would it be okay to give them Hartmann's?
It's not significantly in the bag of Hartmann's.
How much lactate's in Hartmann's, do you know? It's about 29 millimoles, I think. So it's quite, and it's easily, but the thing is lactate, what you're giving is essentially bicarbonate. Okay, a lot of people look at lactate on a blood gas and go, "Oh, they've got lactic acidosis." Well, actually, the lactate itself is not acid, is it? So you're giving as lactate itself. It's a buffer solution, and what you're doing is you're essentially giving them bicarbonate because it gets broken down by the liver to glucose, and that to be able to do that, it essentially needs hydrogen ions. So you're actually giving them a base. Okay, so it's okay to give somebody a lactate-containing fluids if they've got a high lactate. Okay, it may change your lactate level in the blood. So using lactate as a marker of disease may, you just have to think about it.
If someone has liver failure,
you have to have quite severe liver failure to not be able to metabolize lactate. Okay, so how much is important? So itself, as I say, some people will say that they don't want to give lactate containing fluids to somebody with a lactic acidosis. And the other thing is it contains 5 millimoles of potassium. So if you've got high potassium, should you be given lactate? No, it's CSL or Hartmann's. And the answer is 5 millimoles isn't a lot. Okay, you normally need 1 millimole per kilo a day, or 0.5 to 1 millimole per kilo a day. So 5 millimoles is not a lot of potassium. And actually, if you give them normal saline because you're worried about the potassium in lactate and you cause them an acidosis, what you're going to do is actually shift more intracellular potassium out into the extracellular space. So conversely, even though you haven't got, there's no potassium within saline itself, you are causing more potassium to leak out of the cells. Okay, and you might have a higher potassium because of giving saline because you're worried about the potassium in Hartmann's. Okay, and also hyperkalemia can lead to afferent vasoconstriction and worsens renal function. So saline has actually shown to worsen acute kidney injury in patients that are shocked. I think there was a study on aneurysms and stuff. People who had a few leaking aneurysms who were resuscitated with saline had a higher risk of acute kidney injury. Okay. So fluid responsiveness, the panacea. So what do we do? How much do we give? Okay, so there was a study which was got a lot to answer for really, but it's a study by a guy called Manny Rivers, who is an ED consultant out in North America, who looked at patients for sepsis, and what they did is we did end goal directed therapies. So they looked at certain things like CVP, SpO2, and they resuscitated patients with fluids, and they got a better outcome. And since then, it's all been about end goal directed therapy. Can you hear through that? You're okay, yeah. And since then, nobody's been able to reproduce that, and there's been quite a few studies showing that actually it causes more harm. So the answer is how much fluid is just enough, and it's working out what just enough is, because we know that positive fluid balance in the first 24 hours is worse for you. So, you know, it is just about just enough. So all fluid that you give a patient is bad, but then high doses of vasopressin are bad. So it's working out, or inotropes, it's working out how you can reduce your vasopressin to fluid, but not give too much fluid, you know, to worsen outcome. So it's always a balance, isn't it? It's always a balance. So how do we assess CVP? What's people's thoughts on CVP? People still talk about it as using it as an assessment for fluid status. In summary, CVP is out. Nobody uses it. Okay. There's been quite a few meta-analysis in the last few years. I think there's one in Chest in 2008, and there's one in 2013 as well, looking at CVP, even changes in CVP. So CVP, changes in CVP, or trends, and there was no evidence to suggest that it's related to fluid balance or fluid responsiveness. Okay, so the assessment really is dynamic assessment. Okay, I'm not going to talk too much about echo or cardiac output techniques and stuff, but we'll just talk about sort of, you know, the dynamic assessment of fluid responsiveness. So the first thing you do is obviously clinical assessment targeted to patient age and fitness. So you just look at all those normal things that you would do at the end of the bed. You know, is there MAP low? Is there pulse pressure narrowed? Looking at, you know, especially for hemorrhagic shock. Urine outputs, are they delirious? GCS, that sort of, all these sort of things. Capillary things that you do on a daily basis. You're looking at them, asking anybody awake, asking them if they're thirsty. Okay, your body is the best way of telling you that you need fluid. Okay, it's really osmoreceptors in your brain are fantastic at assessing your fluid balance. So actually asking somebody, do you feel thirsty? Quite often they say, yeah, my mouth's dry. So no, if your mouth wasn't dry, would you feel thirsty? Would you want to drink? Okay, so just I think that's a really good assessment. And mottling of the knees especially, and I know Matt Charlton's been doing some research on that, but and what mottling shows you is it just looks at the capillary flow, isn't it? So you're essentially looking at capillary flow, which is delivery of oxygen, which is what we're trying to improve. So any real evidence of poor capillary perfusion. So what do we define as fluid responsiveness? Well, it's important to measure this as stroke volume. So all the studies and stuff about fluid responsiveness are stroke volume. Okay, and a lot of the time when we're doing our assessments, we're just looking at MAP. And MAP itself has got so many predeterminants to the pressure itself, includes systemic vascular resistance and things. You've got, if you're going to do it properly, you're going to measure their stroke volume. Okay, and its response to a fluid challenge, whether that's an exogenous fluid challenge or not, or you know, passive leg raising, which we'll talk about in a second. But it's a response of 10 to 15% with a fluid challenge of about 500 mils. Okay, and the only reason for a fluid challenge is to increase stroke volume. If, and this is the important thing, if you think it's going to increase oxygen delivery. Okay. We are designed as human beings to be hypovolemic. We're always walking around hypovolemic. We're not designed to be hypervolemic. Okay, so if you get sort of attacked by a lion in the Serengeti, your body is designed to hold on to as much fluid as possible. So if you're in a trauma situation and you give someone fluid, their body is designed to hold on to that fluid as much as possible, and it's not used to having that fluid infused into them. Okay. So how to assess, we talked about CVP and pulmonary artery occlusion pressure. Essentially, it's no relationship really, unless it's very, very low CVP and say hypovolemic shock, and that's when you can see the blood all over the floor or whatever. Okay, so it's all about dynamic assessment. Okay, and there's some things that we can do. So arterial swing, so that just gives you a little bit of more information on top of your clinical assessment, looking at the end of the bed, looking at the arterial swing. And if you want to do it more scientific, you do pulse pressure variation or stroke volume variance. Okay, you heard of those terms, guys? Just nod your head. No. Okay, so within this, if you think about the thorax being a box, okay, the box has pressure inside it, okay, and within the box you've got the mediastinum, which is also a box, okay. All the pressures within the body are boxes, and if one box increases pressure, that causes a pressure increase on another box, yeah. So if you're normally, when you're ventilated, you're doing positive pressure ventilation, we're pushing the pressure into the thorax, which is a box, and that pushes the mediastinum in, which reduces the RV filling. Okay, so in a cycle, you'll always get a natural compression of that RV or the your atrium, that side of the filling. Okay, if you're underfilled, then that will be more accentuated because there's not as much pressure in the mediastinum, so you're going to squash it a bit more when you do that. Okay, and that's when you get a swing on your arterial line, or you get what we call a pulse pressure variance or variance with your pulse pressure over a respiratory cycle. And it's the same with the stroke volume. Now that has shown to actually shown essentially to be fluid responsive. So somebody's got that as fluid response. However, the caveats are massive. Okay, so anybody spontaneously breathing is going to change the pressure in their thorax constantly. We don't all breathe in 500 mils and out 500 mils, 500 mils, out 500 mils. All our ventilators are designed for patients to be spontaneous, even if they're on BiPAP, they're breathing spontaneous up and down. Okay, so the stroke volume is always going to, that stroke volume variance is always going to change. They need to be in sinus rhythm, because if they're not in sinus rhythm, beat by beat, their stroke volume will change. So there's so many caveats that actually, in practice, unless you've got somebody paralysed, ventilated with a constant pressure, with no abdominal pressure, and literally nobody in touch them, then probably it's a good measure of fluid response. So, but in practicality, it's not really that good. Okay, but it might give you a bit more information to when you're looking at the big blot of lots of different information. It might give you a little bit more information. Okay, so echo, so static assessment. I say it's no good here. I know I'm not a big echo person, so people might jump up and down about this, but I think the main thing about echo when you've got somebody who's shocked in front of you is it gives you that diagnosis, or it's the potential for finding a diagnosis, and that's important. Okay, so I'm not saying echo static assessment is no good. But if you've got, say, somebody who's come in with what you think is cardiogenic shock because they're having a heart attack, you put a probe on them and it shows that they've got a massive, MR because they've ruptured a cord, then actually you've got a diagnosis and you can treat the patient with cardiogenic shock. So I think in general, it's always good to look at the diagnosis, and echo gives you that ability to do that. But really, with if you're looking at fluid responsiveness, it needs to be a dynamic assessment of echo. Okay, and there are lots of different ways of doing it. So lots of people do IVC measurements, which has the same problems with CVP, because essentially what you're doing is an indirect thing of CVP. But the main thing really is to monitor your stroke volume. So if you give a fluid challenge, you come back and have a look. Okay, and it's all about the dynamic assessment of the patient. So passive leg raise. what I would suggest, if you've got the ability to do a plastic leg raise, like in ICU we do, in theatres it's very difficult. So tell the surgeon to stop. I'm just going to put the patient on their head to assess their fluid status. They'll go, what the hell's going on? But you don't have that ability in theatre. But it's always better to do that than actually giving some fluid which has got a load of sodium in, which is going to take a while for the patient to get rid of. Okay, so how do you do it? Well, you raise legs to 45 degrees by using the bed. Okay? Anybody that starts lifting legs in the air, the patient's blood pressure is going to go up as a response to you messing around with them. So you lift their legs by actually moving the bed around. Okay, and I think you should be measuring stroke volume if you do it. Okay, how you measure it, stroke volume, probably doesn't really matter. You can do pulse contour analysis, you could do echo, you can do whatever, but actually it's validated for stroke volume. What we tend to use is MAP because it's easier and it's at the side of the bed, but there's so many caveats associated with that. You just have to, again, it's a bit of information you take on board, say, well, the blood pressure did increase, but was that because of pain, because I've just caused them a load of pain by they've just had a laparotomy and I put them on the head? Or is it actually a proper increase in their stroke volume? God, it's warm in here, isn't it? Okay. And it's important to recognise that if your patient is, hang on a second, I'll just hide that. If your patient is fluid responsive, it doesn't necessarily mean they need fluid. Okay? Just because you're fluid responsive now, if I gave you some fluid now, your stroke volume would increase. That doesn't mean that you need it, because your body will just piss it out in a bit. So just because they're fluid responsive doesn't mean they need it. But if their noradrenaline's going up, rather than just chasing an aimless number of MAP by increasing the noradrenaline, that's the time to then go, actually, noradrenaline, we know, has got lots of complications. Let's give some fluid to try and reduce the inotrope of the vasopressin. Okay, so just because they're fluid responsive doesn't mean to say they need fluid. All right. What receptors can we manipulate? We talk about preload. I'm not going to go too much on about this, but essentially the main ones we often muck around with is the adrenal receptors for inotropes, dobutamine, adrenaline, that sort of thing. It's G protein coupled receptors. There's loads of different types, but essentially we tend to use dobutamine or adrenaline. But adrenaline is quite a dirty drug because it basically acts on everything. So other inotropes you can use, phosphodiesterase inhibitors. They're sort of classified as inodilators, and how they work is they stop the breakdown of cyclic AMP, which increases intracellular calcium, and in a cardiac cell, that essentially leads to a slightly more prolonged electrical activity, which gives a bit more time for calcium to release from the cytoplasmic reticulum and causes a bit of a stronger pump, if you want. And in the smooth muscle cell, it actually leads to vasodilatation. Okay, so they're inodilators, and they have that sort of benefit, really, of causing, especially with patients with right-sided things, they can reduce your pulmonary vascular resistance and things. There's two types, anoxamone or milrinone. Anoxamone lasts a lot longer, and milrinone a lot shorter. So most people will probably use milrinone these days. And then there's others. There's digoxin, levosmendin, but I'm not going to go through those. Vasopressors, again, adrenoceptors, mainly alpha-1, noradrenaline, high-dose dopamine, those sort of things. And vasopressin, has anyone seen vasopressin used at all? Yeah? So really, vasopressin, they act on the V1A receptors, and as you know, it's essentially ADH. What I would suggest about that is there's been a lot of studies showing that vasopressin doesn't actually change your outcome. Okay, so it's if you want to give vasopressin, that's fine, but essentially what you're doing is just increasing the noradrenaline dose. And if you've got somebody whose adrenoceptors aren't working, then sometimes acting on a different membrane, like a different receptor like vasopressin, that might help things. But my experience and this is probably my own personal experience, but anybody who's on high dose vasopressin, they always lose their fingers, toes, bits and bobs of them. I've seen people use scrotums and stuff. So I'm not overly keen. I think it probably has a role, but it's not something that I like. So how do we assess response? Clinical assessment, hemodynamic assessment, biochemical markers. So normally when you start something, inotrope, vasopressor, whatever, given a fluid bolus, you go back, you do a clinical assessment, you look at all of their normal clinical signs. You do hemodynamic assessments, whether that's stroke volume or just, you know, blood pressure, whatever, but also biochemical markers. What biochemical markers are you aware that we can look at? Lactate, okay, good. So lactate. So we know patients with a high lactate have a high mortality. Okay, but is it a stress response or is it caused by hypoxia? So a lot of the original teaching is all about, you know, can't go into the Krebs cycle, so therefore goes down, pyruvate, gets 2 ATP or whatever, and lactate's an end product. Okay, and that's what people go down, and it's lactic acidosis. But actually, lactate is often produced as a stress hormone almost, where the breakdown of glycolysis or so some organs like the heart and the brain actually use lactate really efficiently. You see, if you think about runners, marathon runners, their lactate would be massive. It doesn't mean to say they're dying. It's just the fact that they're producing energy. Lactate for the heart and the brain really works quite well. Okay, because it produces glucose. So we don't really know, but what we do know is that high lactate is a marker of disease severity and mortality, which was probably a marker of how, you know, stressed the body is. Okay. There's lots of reasons lactate can be high. You know, if you're doing your exams, you know, the classic one in Tech O, I think it is the intensive care manual, is type A and type B lactatemia. It's worth just reading those up so you can talk about them. But there's loads of different things, like vitamin B deficiency can increase your lactate. So there's loads of different reasons for lactate to be raised. A lot of people say, oh, they're septic because the lactate's high. The lactate is not a marker of sepsis at all. It's just a marker of disease, and that's why it's being concentrated on so much. Okay. And what often we see is patients that you know that have been treated massively, but with loads and loads of nebulizers, and you go down, their lactate's 10, and it's because the adrenal receptors have been totally overwhelmed, and their body's producing lactate as a result. Okay, so there's lots of different reasons for lactate to be high. All right. So improving lactate and resuscitation will suggest an underlying improvement in the patient. So we can use it as a monitoring whether your resuscitating is working or not. But you just got to be aware that it may be raised for other reasons. SVO2. Okay, so this is mixed venous oxygen. Okay, the original Rivers study looked at mixed venous oxygen and trying to increase your mixed venous oxygen. So mixed venous oxygen is quite simple to think about in a concept. You've got the amount of oxygen that your body is using over the amount it's delivering compared to the amount that you're giving. Okay, so in theory, if you're not delivering enough oxygen to your tissues and they're over metabolizing all the stuff that you're getting, then you're going to have a low mixed venous oxygen compared to your saturations. Okay, so that's the theory. However, for example, with sepsis, sometimes you get a lot of mitochondrial dysfunction. So that blood that you're giving to the capillary is not, the oxygen's not been taken out of it, so it's just going straight back in. And actually that's a marker of quite severe sepsis and a marker of mortality. So using SVO2 as a marker of sepsis is quite difficult. You just need to be aware of that. Cardiogenic shock, however, where there isn't that mitochondrial dysfunction, having a low SVO2 may be that you're not delivering enough oxygen to the tissues, okay, because it's extracting more. But it's the other thing to think about is if you increase your delivery of oxygen to the tissue, your body is able to then use more oxygen, so its VO2 goes up. So actually the ratio can stay the same. So it's quite a confusing picture, but again, it's another part in the jigsaw when you're looking at a patient to think about. What time is it? Have I gone on too long? God, I have, haven't I? And it's a similar thing to Pco2 gap. Okay, so Pco2 gap, the difference between your venous CO2 and your arterial CO2 shouldn't be less. It shouldn't be more than 0.8 kilopascals. Okay. Now this is there's because it's not dependent on how much oxygen that's being used in the tissues. It's just CO2. CO2 doesn't get used. It can be used as a marker of so a high gap can be used as a marker of poor cardiac output or flow through the tissues. Okay. Is it a predictable mortality or useful saturation was still debatable. Some people still use it as a resource marker, but it might just actually be a marker of disease rather than improve. It's just, you know, it's still looking through the evidence for it. It's a bit scanty, really. Okay, so I'm going to finish now. That's about half an hour, I think. So in summary, treating the cause early is the most important aspect of management. So you've got sepsis, you treat it early, antibiotics within an hour. But also diagnosis, treating the cause is important. Treating the cause, always treat the cause. And basic physiology is useful to try and get an overall picture of what's happening with the patient. If you're going to give anybody fluid because you're shocked, it should be a dynamic assessment of fluid, not just giving them a bag and coming back an hour later. Okay, so you need to work out why you're giving them fluid, what the end points of are the reason for doing that, whether it's going to go, okay, well, we need to reduce the noradrenaline, that sort of thing. You need to think about why you're giving fluid. Okay. And there isn't a right answer. There's just lots of information to assimilate and decide what's the best thing for that patient in front of you. Make an educated guess. If there was an answer, we wouldn't need us as doctors or clinicians to work it out. Okay. Sometimes it's very obvious when they're clutching their chest and going, I've got central crushing chest pain and their blood pressure's. Other times you've got somebody who's a bit septic, could be their heart, could be this or whatever, and you've just got this mixed picture, which is quite often our patients on ICU. Okay, so it's about making an educated guess to all the information that you've got about you around you. Okay, any questions? Stunned silence. If there's no questions, we'll just move straight on. Oh, here you go, Ricky's here.
How are we doing, Alex? You all right?
Yeah, good.
I'm going to make a comment and feel free to disagree with me. You're just saying about giving fluids to get the NORAD off. Yeah. I mean, I suppose my view would be that a little bit of NORAD isn't necessarily a bad thing. Certainly, yeah, when you're at kind of the higher doses or giving fluid with an appropriate kind of fluid challenge and kind of dynamic fluid assessment is definitely appropriate. But I guess what I sometimes worry about is, you know, people being on sort of 5 mils of NORAD and people kind of continually pushing in this fluid in the hope of getting them off the NORAD, whereas actually to me, and again, this is where you feel free to disagree, I think a little bit of NORAD, just trying to get their SVR back towards normal, is probably not as dangerous as pouring in lots and lots of fluid.
Absolutely. I totally 100% agree. It's about what's in front of you, and actually having a little bit of noradrenaline, you know, especially if you've got, say, an epidural on board and it's just to offset a bit of sympathetic tone or whatever, then yeah, it's a balanced approach to the patient, isn't it? And I don't think fluid is a good thing, and that I hope that comes through on the you know, I really think that we need to think about why we're giving the fluid. And if it is, you've got, you know, if you're on 1 milligram of NORAD or something and you've got a potential for causing bowel problems or liver problems or whatever, you know, one of the problems we have all the time is people chase mean arterial pressures and they don't think about flow. and it's about you know, you can come in the morning and you see that a map has been set in overnight, and the NORAD has just gone up to match that map. And it's about having a balanced approach to, you know, perfusion rather than pressure. So I totally agree with you.
Oh, good. Yeah, I mean, certainly from my experience, kind of, you know, we get a lot of pancreatitis and things like that, and you know, I do see people kind of trying to chase the NORAD away with fluid, and then, you know, a week later, your patient's like sort of 10 litres positive and got edema coming out their ears. So yeah, that's certainly my experience, really.
Thanks, Ricky.
Cool. Cheers.
Mike, you had your hand up, didn't you? No? Okay. Anybody else? Hand up?
Briefly, Alex, sorry. It was just to echo your point that you have to have an understanding of the diagnosis and your reason behind it to decide between noradrenaline or fluids. That is the most important thing. The number of times we've come on morning round and found a patient on 3 milligrams of noradrenaline, and actually their fluid balance is significantly negative or even, and 2 hours later with 2 litres of fluid down and the noradrenaline's halved, and you're in a completely different situation. But it's actually understanding what's going on from a diagnosis point of view. So it's just echoing what you said in your presentation, that diagnosis is key with any type of shock.
And I think the sort of this whole goal-directed therapy really, and also a lot of the way medicine's going in terms of, you know, there needs to be a protocol to this and a protocol to that, and actually the thinking behind stuff often gets missed, I think. And goal-directed therapy, I think, you know, the goal is always, you know, perfusing the tissues and working out what's going on. So yeah, I agree with you. Simon, you got your hand up?
Yeah, hi Alex. Thank you. What I was going to say is, I don't know if you mentioned it, but another way of assessing fluid responsiveness is, rather than giving fluid to affect the preload, is to increase intrathoracic pressure from the ventilator. It's a bit riskier, and you kind of have to know what you're doing, and you have to be aware of how much NORAD on the same, but you're basically doing the reverse of a fluid challenge. And so if they drop their cardiac output as a consequence of increasing intrathoracic pressure, you can also make an assessment. You can say, well, actually, they probably need more volume.
Yeah, there's a study about that, isn't there? And I've seen it done once, and there's an asystolic arrest, and so I haven't bothered doing it again.
Oh, but I do quite a lot. That hasn't happened yet.
But it's a good question. So when you're doing, say, a passive leg raise, I find actually not just the increase in stroke volume. Actually, when you put them back and you get a sudden drop, that would suggest as well to me that their fluid status isn't great. So you're right, which is a similar thing, isn't it? You're sort of changing the pressures around. But any sort of so you're talking about an end expiratory hold and looking at their blood pressure as a result of that. Yeah.
Well, the easy way to do it is put them onto APRV. Essentially, what happens is there's been loads of intrathoracic pressure for a sustained period of time, and you see what happens. The other endpoint you can look at, and again, I can't remember if you mentioned this, was end-tidal CO2. There are some studies that have looked at end-tidal CO2 as a marker of fluid responsiveness, as a good indicator of increased cardiac output. It's just much harder because it's much smaller numbers unless you convert it to millimeters of mercury. But that's another endpoint that people do use.
Thanks, Simon.
Hi everyone, my name is Henry, one of the registrars at Leicester Royal ICU. I've got a short presentation about a paper that has been published, I think, a few years ago about using intra-aortic balloon pump for patients, specific patients in the 600 patients in Germany with cardiogenic shock after an MI. So the specific question about this trial is that whether a intra-aortic balloon pump, IABP, actually improved mortality rates in patients who suffered from cardiogenic shock and an acute MI compared to the standard treatment. The reason for that is that currently the balloon pump is used quite often, but then it's also included in some guidelines. However, it is often based on clinician experience and clinical judgment rather than a kind of a trial or any research that's been done. There's a lack of RCTs for this kind of patients. The people who did the research did a pilot research. So the SHOCK trial has included 45 patients, and they couldn't see any significant difference. So they have, after the pilot trial, they've done this SHOCK2 trial, including 600 patients. And their hypothesis is to see whether the use of the balloon pump as compared to medical treatment, whether it will reduce mortality in patients who has an acute MI, which then subsequently develops cardiogenic shock for patients who they were going to plan to do PCI anyway. It is a multi-center trial based in Germany, 37 hospitals in Germany, run across from summer 2009 to 2012. Obviously, it can't be blinded because it will be very obvious that the patient's got balloon pump in situ, but it is centrally randomized, and it is not, well, they said it's not biased, it's not influenced by the companies who made the pump, and it is the intention to treat trial. They've enrolled 600 patients, and they split them roughly equally in terms of the treatment arm and the best medical treatment. These are the inclusion criteria. They're quite strict. They've got a definition for cardiogenic shock. So any of these criteria, they would enroll the patients for the balloon pump or the medical treatment arm. And all these patients would have had an acute MI, either an STEMI or a STEMI, and they were going to do a PCI anyway. So those treatments remains the same, and the only difference is whether they will put a balloon pump in them. They've got a long list of exclusion criteria. So basically, patients who are not suitable will include patients who've been arrested for a long time, had any contraindications such as significant peripheral vascular disease, very elderly patients with massive PE. So they've excluded a whole lot of patients that are potentially unfit or will have a very bad outcome anyway. So these are the lists. In terms of, so this is a table that's kind of describe the patient characteristics of the IABP arm on the left there, and the control arm of the treatment. But this is just to show, I'm not expecting you to read the whole table, it's just to show that they have quite balancedly divided the 600 patients. So you can see there's 301 patients in the balloon pump arm, and there's 299 patients in the control arm of the trial. Yet again, this is just to show that they've kind of looked into what the patients were like before they randomize them into the treatment and the control arm, and just to say that they've divided the two groups into quite evenly. So what did they do with the treatment arm of the patients? So they would put a balloon pump before or immediately after the PCI, and is triggering via ECG electrocardiographic triggering 1-to-1, and they would put the balloon pump in until they are hemodynamically stable. So basically, the cardiogenic shock has disappeared for more than 30 minutes before they will take them out, and before they will wean the balloon pump and take them out. And majority of patients would have had the balloon pump for about 3 days. And this is just to say what medical treatment has had the patients in the control arm. So in summary, this is the primary endpoint is the mortality, whether the balloon pump has improved mortality at 30 days, and the outcome is actually not significant. You can see the relative risk with the balloon pump crosses between 0.79 to 1.17 with a non-significant p-value as well. And they've looked into the secondary outcomes. So basically all of the secondary outcomes in terms of stroke or any other problems such as bleeding or other other ischemic events, none of them come back as significant. So basically, the result shows that the use of balloon pump for patients who had an acute MI and a cardiogenic shock, it has shown no difference using the balloon pump or the best medical treatment. In terms of thinking about this trial, there are some limitations and some strengths to this trial. Obviously, it included 600 patients in 37 centers in Germany. They have got a central randomization of those patients, and the table showed that the patient characteristics before the randomization has been quite balanced on both treatment and the control arm. But obviously, this is a trial that you can't really blind the balloon pump. There are some protocol violations in a way that some patients on the control arm were moved to the balloon pump arm. So some of the clinicians decided to put the balloon pump in anyway, despite being randomized to the medical treatment arm. And again, it shows that actually the use of balloon pump is quite clinician dependent from what we can see. And they've not followed up patients after the 30 days. So that's it. Does anyone have any questions? Great, thank you.
Very good. Who's doing the next one? Is it?
Alex Stram was doing it, but he's gone home.
Yeah. Alex has gone home, so he's going to do it next week.
Alex will do it next week. Okay.
Henry.
Hello.
Why do you think we still use it?
Well, I think that the theory behind the balloon pump made sense. It's still included in some guidelines, and some is because of the culture, I guess. Is there a particular reason?
I have no idea. I'm just...
I think but when you explain it to people, it makes sense how it works, and improving diastolic perfusion, reducing the work.
So one thing I've just asked Eden, because I can't remember, but in Shock 2, did they use any echocardiographic? They didn't. Okay. So
it was like a systolic of less than 90 or 15 minutes, which, you know, if you get away with 1 or 2 mils of NORAD, you probably wouldn't necessarily put a balloon pump in them.
So I think this is part of the problem. So what we do know is that patients who've got distributive or vasoplegic type forms of shock actually have a worse outcome on mechanical support.
Yeah.
So what do people think about that?
So it wasn't specified what they think about the reason of shock is. They just based it on people who had an end-STEMI or STEMI, and then they had hypotension. Therefore, they put a balloon pump in. I guess what they haven't looked into is to other confounding factors such as vasoplegia.
So I think this is part of the problem, and there's another study going on at the minute called Euroshock, which is looking at patients who've got cardiogenic shock post MI, to see whether VA ECMO is beneficial. But again, it's not based on any actual concrete evidence of them having a cardiogenic nature of their shock. And a lot of people who've had MIs or cardiac arrest will all have an element of like a SIRS type response and vasoplegia, and they will do worse if you put them on VA ECMO. And the same is probably true of balloon pumps. So I don't know. It's just thought provoking. I don't know the answer.
It's often quoted as like the trial that killed the balloon pump, but obviously it hasn't. And I think that's because a lot of the reasons that you just said, Matt, just is that that's not how you would use it. Like their patient population isn't great. There's also lots of studies that have shown that if you just want to augment cardiac output, it's nowhere near as good as things like the Impeller or ECMO. But it's obviously its unique qualities with regards to increasing your diastolic pressure and thereby coronary perfusion, especially if you've struggled in cath lab with your PCI and you maybe got incomplete reperfusion. So it does have a cohort of patients it's specifically good for, but you've got to ask yourself what you're trying to achieve by using it. Is it just to make the blood pressure better, or do you actually really need a significant increase in cardiac output?
Thanks, Henry.
Otherwise, thanks everybody for presenting.
Thank you.
Lovely week, bank holiday weekend in the sun.